In chapter 15, we're going to take a look at blood flow and the control of blood pressure. So we're going to first take a look at blood vessels, blood pressure, how the diameter of the blood vessels plays a role, the resistance in the arterioles, distribution of blood to the tissues, regulation of cardiovascular function, the exchange that takes place in the capillaries, the role of the lymphatic system, and then also at the end some pathophysiology about cardiovascular disease. So here's your first an overview over the cardiovascular system. You have the heart as the big pump right here. That's our starting point, and then we're going to go out of the left ventricle into the aorta, into toward all the body tissues. And you can see how the aorta, as a single vessel, accommodates all that blood flow out of the left ventricle, and then we're going into arterioles and then smaller and smaller vessels until we go into capillary beds. In the capillary beds right here, this is where the exchange takes place. Then once we come out of the capillaries, we're going to have to collect the blood into venules, into larger and larger vessels until we come back to the right side of the heart, go up to the lungs for reoxygenation. We'll start all over. So let's take a look at blood vessels. Basically, you have arteries, arterioles, capillaries, venules, and veins. Besides the capillaries, all of the other vessels have 3 layers. So any artery or even any vein has 3 layers. Take a look at the outer layer right here. That's connective tissue. It's pretty tough. Then we have a muscular layer. That's the middle layer. And it's fairly big in arteries and arterioles, but pretty small in veins, as you can see right here. And then the inner layer is endothelium. That's just a very fragile kind of layer in the center. In a capillary, the only thing you have is an endothelium, so just one layer, and these capillaries are naturally leaky because of that. Also, you don't have any muscle layer in the capillaries, so you cannot really adjust the diameter. In an artery, you can easily adjust the diameter by contracting the smooth muscle that's in this middle layer right there. So here we'll take a look at microcirculation. The idea here is to take a look at these capillary beds. So you're going here in from the arterial side, and then you're going into a capillary bed. Here you have the exchange vessels, and the idea here is that there are sphincters that can increase or decrease the diameter of these vessels, or basically shut down blood flow into certain areas or increase it more into other areas. So you have options of where to divert your blood. So here would be a precapillary sphincter, and if it's relaxed, then blood flow goes into all of the tiny little capillaries right here. So we're going into all sorts of directions here, following the arrows coming out then on the venous side. Now, if you are shutting down one of those precapillary sphincters, then you will divert blood only to the open areas. So these areas over here, they are basically shut down, and you are just diverting the blood into this capillary right here and coming out on the venous side. So the exchange always takes place in the capillaries. What are we talking about? Exchange of gases, CO2, oxygen, and then also nutrients that are being delivered and the trash that's being picked up. So all of this exchange is taking place in capillaries. So these capillaries, they have to be adapted to maximize exchange, or the ability to exchange. We don't have any muscle here, and we basically need to do everything in order to facilitate exchange. We have the ability to decrease or increase capillary permeability a little bit, but in essence, capillaries follow the pattern. They're either leaky or leakier or leakiest. And so here are the types of capillaries listed. So here, the continuous ones, they're leaky. The fenestrated ones, they're leakier, and the discontinuous ones, or sinusoidal ones, they are the leakiest ones of them all. The continuous type of capillaries, the leaky ones, we will find in muscle, lung, adipose tissue. Fenestrated ones, fenestra means window, so they have pretty large pores, and those we will find in the kidneys, endocrine glands, intestines, as an example. Lastly, the discontinuous type of capillaries, they're also called sinusoidal. They have very large gaps between the cells, and they are the leakiest capillaries that you could find. They are present in the liver, spleen, and the bone marrow. Now let's take a look at some of the properties of veins. You don't have another pump on the venous side, so it's kind of hard to get the blood, especially out of the legs, back up toward the heart against the pull of gravity, of course. So there's a lot of blood down here, and how are you going to get it back up in this direction? Well, the veins have valves, and these valves, they prevent backflow. So if the skeletal muscle here contracts, as you can see right here, it's contracting, and so it will be pushing the blood that was in here, it will push it upwards, and then once the muscle relaxes, that's when we are going to have the valves will stop the backflow. So we're going to push up the blood, and it won't be able to come back down. There's a reason why we would run these veins through a skeletal muscle, especially muscle that helps to maintain posture, for example. So because these muscles, they basically contract all the time, and so you want to run your veins through these kind of muscles in order to take advantage of the system right here. So you have the valves in place, and every time the muscle contracts, it's pushing the blood up back toward the heart. Here's another term that you should know. It's called angiogenesis. Genesis is to make or to create. Angio is vessel. So basically that's the development of new blood vessels, which is basically controlled by cytokines. And so these are messenger molecules. They promote cell division. And here's some examples. The vascular endothelial growth factor, VEGF, and the fibroblast growth factor. Those are contributing factors. So these are messenger molecules that promote mitosis, cell division, to generate more vascular tissue. Inhibition would be with angiostatin and endostatin. Together, those would be the controlling factors that control angiogenesis. A couple examples here. You have up here malignant tumor growth. So when a tumor is growing, it needs fresh blood supply, oxygen and nutrients, and it will generate its own capillary bed. And that's why a few years back, or many years back actually, people started to think that maybe that would be a good cancer therapy if we have anti-angiogenesis medications, because that would inhibit the cancer from making its own capillary bed and feeding itself. Another time when you need a new capillary bed would include after injury, or for example in pregnancy when the placenta needs to be made, and that's a big capillary bed that needs to be made. Next thing we should consider about blood vessels is the elasticity that's necessary to accommodate a gush of blood that's coming out of, let's say, the left ventricle. So here the extreme example, of course, would be the aorta, and here's your ventricle. When the ventricle contracts, it's pushing out a gush of blood into the aorta, and that will bulge out the aorta to some extent. So it's going to look like this rather than a skinny vessel like that. And so there needs to be some elasticity and recoil ability to accommodate that. So here, once the ventricle relaxes, that's when you need that recoil ability to where the blood vessel assumes its regular shape. Now let's take a look at the relationship between pressure, flow, and resistance. If you have listened to the recordings on the lab about the blood pressure lab for this week, then you already know about this formula, that the flow is proportional to the change in pressure over the resistance. And you can take a look at these parameters right here, but I think we should just move on and take a look at how this works. So here we have the systolic pressure up here on top. That's the maximum pressure out of the ventricle, and then the diastolic pressure would be here on the bottom. And so when the blood leaves the left ventricle, that's when you are generating the highest pressure. Here is 120. So over here we have the pressure, and then when the ventricle relaxes, there's still some pressure left, and that will be the diastolic pressure. So you need to know about systolic pressure, diastolic pressure. That would be the pressure after the ventricle relaxes. And the difference between systolic pressure and diastolic pressure is the pulse pressure. Now, when you're taking the average pressure between systolic and diastolic pressure, that is calculated as the mean arterial pressure, and it always will be closer. So do you see this line right here? That's the average pressure in your main arterial system, so in the aorta and the associated vessels. That mean arterial pressure will always be closer to the diastolic pressure because we're spending more time on the diastolic side in the cardiac cycle as opposed to the systolic side. So you need to know how to calculate pulse pressure and mean arterial pressure. Those are two calculations that are required for the lab as well as for the lecture. And the pulse pressure is simply the difference between systolic pressure and diastolic pressure. The mean arterial pressure is the diastolic pressure plus 1/3 of the pulse pressure, but then there's also another formula, and we'll take a look at this here. So again, the pulse pressure would be the systolic pressure minus diastolic pressure, and then the mean arterial pressure is the diastolic pressure plus 1/3 of the pulse pressure. But then here's the other formula. So here's the other formula that you could use. The systolic pressure plus 2 times the diastolic pressure divided by 3 gives you the same result as this mean arterial pressure calculation. Assuming that we have a normal blood pressure of 120/80, the pulse pressure will be calculated as 120 minus 80, which is equal to 40 millimeters of the mercury. And the mean arterial pressure, once you have the pulse pressure, it's probably easier to use this formula. It's given right here. The 40 divided by 3 is 13.3 plus the diastolic pressure of 80 right here. That adds up to 93.3 millimeters of the mercury. So that's how you would calculate pulse pressure and mean arterial pressure. Now, in order to measure somebody's blood pressure indirectly, you're going to use a sphygmomanometer. And the principle is that you are collapsing a main blood vessel. It's typically the brachial artery that's being used. And so you are collapsing this blood vessel that's running under here. You're using a cuff. You are pumping up that cuff to where the blood vessel is completely compressed, so there's no more blood flow going through. It's completely occluded. And then you're gradually releasing the cuff pressure, and when first blood is going through here, then you're hearing the sounds of chord cough. So there will be some, of course, there's resistance to flow because the vessel is not completely open, and you're going to hear these sounds of chord cough, the chord cough sounds. Those sounds, they will continue until there's no more obstruction to the vessel at all. It looks like this. And so you will equate the first sound of chord cough and the pressure at which it was measured, that's your systolic reading. And then once these sounds stop, that will be your diastolic reading. And again, a normal reading of blood pressure would be 120/80, with 120 being on the systolic side and 80 on the diastolic side. Now let's take a look at some of the factors that influence the mean arterial pressure. So for one, of course, the blood volume is going to play a role. More volume, it means more pressure. And the effectiveness of the heart as a pump, so how well it can contract, how strong is the contraction, that is also determined and determines the heart rate and the stroke volume. So these are big factors right here. Then, of course, the resistance of the system to blood flow. Is there any occlusion? Are there any deposits? Is there any hardening, atherosclerosis, something like that? So the diameter of the arterioles. And then we also have the diameter of the veins that determines or contributes to the relative distribution of the blood between arterial and venous circulation. And here's a chart that I like very much, showing that the mean arterial pressure is determined by various factors, and that's how we're going to continue in the next section.